When considering implant treatment in a particular case, the practitioner has to evaluate whether oral implants are indicated for this particular patient, in this specific oral situation, and within the framework of a comprehensive reconstructive treatment planning. During the last decade, the use of implants has widely spread among practitioners with increasing demand from patients and heavy marketing by the companies. However, reports about alarming implant failures are emerging in the literature, which is mainly related to implant malpositioning as a result of poor treatment planning. In addition, the number of late implant failures associated with peri-implantitis is increasing. Since peri-implantitis is caused by microbial biofilm, and patients with a periodontal history are at higher risk, patient selection, personal oral hygiene, and professional maintenance become important factors when trying to determine from the outset an optimized prognosis for a particular patient. The increasing number of malpractice lawsuits means a thorough evaluation of patient history and an awareness of the risk of treatment failure and complications is required, as implant treatment outcomes are not as predictable as that of the conventional therapies with fixed FDP or removable dental prostheses RDP, particularly in circumstances where aesthetic considerations are the overriding concern. The application of a systematic patient assessment and a straightforward diagnostic planning procedure facilitates an optimal treatment recommendation and helps to avoid failures and complications. In the following review, the current literature has been examined in order to analyze the available evidence on patient assessment for implant treatment. Special consideration is given to three typical situations: single tooth replacement, partial edentulism, and edentulous jaws. A series of consultations has to take place. During the first consultation, possible implant contraindications should be ruled out during the course of the examination. A medical questionnaire will aid in the initial interview and includes past and current diseases, temporary and long-term medication, smoking status, and special dietary features. Additional questions address the age of any existing prosthesis and the presumed reason for tooth loss: caries, periodontal disease, trauma, or others. Recurrent decay indicates a high caries activity, which might be in addition to the required diet recommendations, a decisive factor as to whether to maintain or replace a questionable abutment tooth. Patients with a periodontal history are at higher risk for potential peri-implantitis leading to late implant failure. This knowledge may also affect treatment planning. Anterior tooth loss following accidental trauma is frequently associated with advanced alveolar ridge defects, and the potential involvement of adjacent teeth has to be ruled out. In general, the insufficient bone quantity for implant stabilization is no longer regarded as a contraindication due to the successful application of augmentation procedures using guided bone regeneration. The additional effort, however, should be within reason, and the patient must be willing to take upon herself the surgical burden, especially when two-staged procedures with bone grafts from extraoral sites are needed. General contraindications for implant treatment are rare and mainly related to an increased risk for patients undergoing the surgical procedure for patients in poor general health, which could interfere with the surgical treatment and require medical supervision. The chronological age per se is not a contraindication for implant placement, but, particularly in older patients, the decision should depend on the treatment necessity and the patient's ability to tolerate the procedure. In young adults requiring single tooth replacement in the anterior region, implant placement should be postponed after the age of 25 due to the prolonged changes in anterior face height and posterior rotation of the mandible, particularly in women. 5. Until 2000, several general diseases were considered as strict contraindications, such as metabolic disorders, cardiovascular diseases, systemic bone diseases, or disorders of the hematopoietic system. Today, these conditions indicate implant treatment under medical supervision, and particular precautions should be considered, such as antibiotic prophylaxis, calcium substitution, or substitution of coagulation factors. Erosive disorders and hyposalivation with the symptoms of xerostomia are not a contraindication for implant treatment. On the contrary, since patients with hyposalivation are at a higher risk of developing caries lesions due to the decreased salivary buffer capacity and reduced demineralization of enamel and dentine, implants may be favorable over teeth with questionable prognoses. For more on dental implants treatment planning, please visit our website by clicking the link below this video.